Good morning. My name is Richard Wexler, and this is Caring in America, the podcast for caregivers and care recipients. So, like I always do on every episode, who am I? How did I wind up doing a podcast like this? So, go back about 17 years. I'm minding my own business in the software industry. My wife and I had gotten married later. We have two young children, 11 and 7. And in the summer of '05, the phone starts ringing and we get 4 phone calls. All 4 of our parents are extremely ill. Had we planned for this? Of course not. We're the average couple. We're not going to talk about this. We're not going to plan for it. But then all of a sudden, we find ourselves in this adventure, an adventure that lasted for 14 years until the last parent passed at 96 in 2019. So if you go back about 16, 17 years, started my company Points of Life because I realized I could barely spell the word care. And after talking to a few people, I found that others were similar to me. So started educating, eventually educated all over the country about this little tiny word care. Fortunate enough to educate thousands of people, but about a year ago said to myself, how do I get in front of more people? Started looking at a podcast that we launched earlier this year with that goal of trying to help people understand what care is, what it means, and how it applies in their life. We have 2 special guests this morning. I'm going to introduce both of them by their bio, and then I will ask them to speak. First, Danielle Barnes. She has worked with St. Luke's Hospice for a little over 9 years. For years, she oversaw all the clinician schedules and referral intake. She was able to form a very close relationship with social workers and case managers. And she recently moved into the community outreach for hospice and their home health program. And Danielle loves preaching about their home health and hospice teams and how they can offer all the many contributions that make them stand out in the community. Next, we have Kendra Teets. She's been a nurse for almost 20 years. She started her career as a neuro nurse and then transitioning to her passion, which is hospice, about 17 years ago. She is currently the hospice clinical manager. She has her master's degree in nursing leadership and management. And she considers hospice nurses the Navy SEALs of the nursing profession. They exhibit some of the highest levels of critical thinking required to guide patients and their families to end of life. Kendra is very proud to be a nurse and even more proud to be considered a hospice nurse. Are you ladies there?
We
Good
are.
morning. We are here.
Good morning on this this cold day in the Boise region. So, what I want to do this morning, I want to talk about St. Luke's health system and specifically talk about home health and hospice. And having been doing this now for about 18 years, and you guys have been doing this for a long time as well, what I've heard out there, and I'm guessing maybe you guys hear this and one of you guys can speak to this, is home health the same thing as home care?
It's not. Even though the two titles sound really similar, it's actually quite different. So, both services are provided in someone's home. But the big difference between the 2 is that home health provides a clinical or skilled need by a licensed clinician, whether it be a nurse or a therapist for somebody that's deemed homebound. So, for some reason, they are having a hard time going to the doctors, going to the grocery store, and they need to remain in their home for a certain amount of time. Um, so, home health can put a nurse in the home to take care of, let's just say, wounds, for example. Um, and they also can provide physical therapy, occupational therapy, and speech therapy.
Wow,
Now,
interesting. Go ahead, Danny.
yes. Now, home care, even though it sounds really similar, is support and assistance from a non-clinical or non-skilled professional caregiver. So these are things like toileting, dressing, laundry, cooking, taking medications. And the beautiful thing about home care is that we often have family members, spouses, children who get caregiver burnout, which I think that you have experienced in the
Yes.
past, Richard. And so this can really, take some of the weight off of the caregiving shoulders.
Very interesting. So let me recap a little bit, and so hopefully our audience understands. Because I hear people all the time, oh, mom's got home health, mom has home care. And I really don't think they understand the differences like you just talked about. There's further differences, which we'll talk about in a few minutes. But as you're talking about bringing a registered nurse in, bringing someone in that can address wounds, bringing someone in that can actually provide medicine. And also, I mean, we hear all the time that our older mom, older dad, older grandparent fell and broke a hip and may need some type of physical therapy, or maybe they're recovering from a stroke and may need some type of therapy as well. Is that what we're talking about, Danny?
Yes, that's exactly what we're talking about. Yes, and that's coming from a physician that puts in a referral for these people, and the referral is going to say why that particular patient is homebound and what specific skill needs to be provided in the home.
Got it. Let me ask you a question, and I know we actually saw this in my own personal situation with my family, where a patient is in the hospital. Let's use the broken hip example. And then it's time the person has gotten through surgery, gotten through anesthesia, is doing okay. It's time for them to be discharged from the hospital. And I know in a lot of situations, that means being sent to a skilled facility, skilled nursing. But it sounds like, and I don't want to put words in your mouth, you can correct me if I'm wrong, there may be a second option where they can actually have that therapy done in the home. Is that correct?
Exactly, where some people are going to be discharged from the hospital to go to a rehabilitation center, some are going to be placed in the home where they can get all these services at home instead.
Wow. And you're talking about, I believe, like physical and occupational therapy, respiratory therapy. I mean, there's quite a different services that you guys can provide for that patient as long as they're set up and comfortable in their home. Again, I don't want to put words in your mouth, but am I kind of going down the right line, Danny?
No, you absolutely are. That's perfect. So the physician will state on that referral what skilled services need to be, provided. It can be nursing and physical therapy, or one or the other, and that will all be kind of dictated by the physician. But yes, the comfort of your own home.
Perfect. And then are there situations where maybe you may bring some counseling in, like for nutrition and things like that?
Absolutely, yes.
We do have dietary consult, speech consult on the home health side. Richard, I wanted to interject and just back up a moment, if I may.
Sure,
I
Kendra.
just wanted to clarify back in the day when the home health benefit was offered through Medicare, private insurances, and Medicaid, it was called home care. And so it has evolved over the years into now it's called home health. So home health and home care can be used interchangeably, but they are not the same. So St. Luke's Home Health actually used to be called St. Luke's Home Care, even though we did not provide custodial care like home care provides. We provided rehabilitation, but we've since changed our name to St. Luke's Home Health because it was getting confusing to all those home care, custodial care companies in the community.
Got it. And let me ask a question, and either one of you ladies can answer this. And again, I don't want to put words in your mouth, but my understanding, if you're getting home health, I mean, this was a situation actually with my own mom. If you're getting home health in the home, they're not going to be there 24 hours a day. So if this individual is still having difficulty, maybe going from a wheelchair to a walker, using the facilities, so on and so forth. And again, correct me if I'm wrong, do you also need potentially home care or a family member or someone in the home that's taking care and helping the individual with those needs as well?
Yes, Richard, that's a good point. With home health, there are goals that need to be achieved. And so, mom needs to get to the point of walking 300 feet a day. So the physical therapist has to, based on the plan of care, say that Susie Smith will be able to walk 300 feet by the end of 6 weeks. So it's a short-term service, and the goal is to quote unquote graduate them off. So
Got it.
it can mean that there also needs to be custodial care, but if a patient's in the home needing home health, there could be a level of custodial care that can be provided by a home care service.
Very good. And I wanted to make sure people understand that because I'm sure you guys have probably heard that. I've heard that. Well, mom has home health. I understand what that means. So, and the kids live multiple states away from mom. Not like they can get in the car and drive there, but mom will most likely need someone with her for a period of time, helping her, with the other needs. I think, Danny, you talked about this briefly. How is home health normally set up?
Yeah, so that's either going to be from the patient's primary care physician, or if they're discharged from the hospital, then that physician can order home health as well.
Okay, very, very good. Pretty easy and simple to do, I'm assuming.
Easy, simple to do. It is going to be physician based, whereas home care, you're not going to need that requirement from a physician.
Got it. And then a key question that most people are going to have, and I want to inform my audience: how do you pay for home health?
So that's a good question. Medicare will pay for home health, and most private insurances will pay a portion of the cost as well. It really varies depending on specific plans and state requirements. So, just like with anybody, if it's something that is needed or ordered by your physician, please look into your private insurance policy beforehand just to see the specifics of what's covered.
Very interesting. And folks, for a lot of you, a lot of people hear this all the time. Mom's set up, she's been on Medicare for 20 years, everything's fine. And we understand most of the time Medicare is not going to pay for either home care or living in a community like an assisted living. But the good news that Danny is talking about, Medicare does pick up the bill for home health. So, for a lot of people where we have the worry about expenses, that's alleviated with that information. Anything else you ladies would like to add as we kind of finalize our conversation about home health before we move into hospice? Anything else?
Yes, Richard, thank you. One of the big takeaways is that you need to be homebound to be able to receive home health benefits, meaning it takes a taxing effort for you to get out of the home to go anywhere for, dinner, get your hair done, those types of things. So, because if you're able to leave the home and go receive outpatient rehab, then that means that you don't need to receive care in your home.
Understand. Now, one clarification there, is it possible to receive home health in a community like an assisted living?
Assisted living is the only facility that allows home health. Nursing facilities do not allow home health in there because oftentimes skilled nursing facilities are also rehab facilities and have their own PTs and OTs on staff.
Very interesting. So again, someone, we'll call her Mrs. Jones. She's 85. She's already in an assisted living facility here in the Boise area. She broke her hip. She's being discharged. She can go back to that assisted living, receive the home health from you folks, where she also obviously has other folks looking after her in that community, that facility. That's great information. I'd like to move on to our second topic, which is hospice. And that can be a difficult topic for a lot of people. A lot of people, unfortunately, don't really understand what hospice is. So, if one of you could address that kind of broad question, what's hospice?
Well, hospice is my passion. Hospice, simply put, is care at end of life for whatever that looks like. And so, in general, hospice walks alongside someone in their disease journey, really navigating the what ifs and what could be, and providing symptom management and quality time, comfort time. And if we get quantity out of the deal, then we're getting a two for one. And so hospice care is really the one time when the doors open wide for resources for a patient and their family.
Got it. Got it. End of life. And that can be a very difficult subject. When along this care continuum are we starting to talk about hospice? When is that subject potentially coming up?
Yeah, that's a great question. In my professional experience, we always like to see those conversations happening sooner rather than later. However, hospice is still that kind of four-letter H word and kind of the elephant in the room
Yeah,
sort of philosophy of care. And so, earlier referrals to hospice care is a thing. But the general rule of thumb is if you have a 6 month or less life expectancy and your goals of care are in alignment with end of life, then those would be the two big qualifiers for hospice care.
interesting. And then a similar question that I ask you ladies about home health. So now mom, that 85-year-old, has moved into hospice care. Does that mean that someone from hospice is there 24 hours a day, or does she still need that family member, someone from home care, or and maybe you can answer this as a second part of that. Can hospice be delivered if mom is in an assisted living community? So, first of all, Is hospice gonna take care of all their needs, or does she need other folks as well?
So, one common misunderstanding with hospice is that we are going to provide 24/7 care. Our clinicians don't move into the home um, or provide custodial care, but we're just kind of that layer of support that's needed at end of life. For example, we have some patients that, due to their needs, are seen every day. They may be in an imminent state. And then we have other patients that are doing quite well, and they still are in that 6 month or less category deemed by their physician, but are stable. And so we can see them once every couple of weeks. It really just depends on the stage that that person is in and their individual needs.
Interesting. And backing up a little bit, a physician, I think you guys said this needs to be involved. Does there have to be a physician's order to move someone into hospice care?
Yes, so you have to have a referral from a physician, and that referral is going to state um, what the terminal diagnosis is, and that the life expectancy of this patient is 6 months or less. Now, a lot of people see this and envision that after 6 months, you're drawing the line, it's over. And really, it's quite opposite what ends up happening. People stop these, invasive, life prolonging treatments. They come onto our service. We are managing their symptoms, and overall, they're more comfortable. They're happy. They're enjoying life, and as long as you kind of are in that category of a terminal illness with that 6 month or less life expectancy, we have had people on for as long as 4 years plus, I would say.
Really?
So it's
Wow.
really interesting.
Very interesting. So I've heard this term. I know you guys are aware of this term. I wanted to make the audience aware as well. Can you actually graduate from hospice care?
Absolutely. We are excited when that day comes, as we know patients are managed and stable and not in the end of life trajectory. We do careful assessment when those times come, and we really are evaluating them for several weeks before we feel like maybe they are no longer in an end of life state.
Very interesting. So, because I'm sure a lot of people, I don't want to put words in people's mouths either, but they think this is definitely end of life. Mom is moving towards the end, dad, grandparent, etc. But there are those situations where someone actually graduates and goes back to whatever their life was, maybe with home care, maybe with home health, maybe in a community before they were moved into hospice care, which kind of leads me into my next question. I know a lot of folks that I've talked to over the years think that hospice is something that takes place in some building someplace. Where can hospice care actually take place?
That's a good question. And I think in the past, and maybe even in some states, there are, hospice facilities. Um, but usually hospice takes place wherever the patient resides. So they can spend their last days comfortably in their home, assisted living facility, skilled nursing facility, or certified family home. And then just recently, St. Luke's actually launched our inpatient hospice program.
Wow.
And this is where a patient that is more imminent can stay in the hospital, receive all the benefits of hospice care as if they were at home. And this is also including 13 months of that bereavement support for the family. So even
Wow.
though it may be a shorter stay, since they're in the hospital, their family gets that extra level of support as well.
I mean, that's fantastic information. The whole goal here is to make folks as comfortable as possible. And from what you're telling me, Danny, they can stay where they're currently residing. And with St. Louis situation, even currently in the hospital. And then I like that last piece that you added as well, being able to bring in grief support for families and so on. And I believe you said you offer that up to about 13 months. Is that 13 months then after someone actually passes?
That's correct. Yes.
Very interesting. So as we've talked about with home health, let's talk about from a similar vein because I've had people ask me this, how do we pay for hospice? How does that work?
So the main source is Medicare, and that is going to pay 100%, including medical equipment, medications, supplies, let's say incontinent or wound care supplies, and it can even pay for like a short-term respite care for up to 5 days at a inpatient care facility to give caregivers a little bit of a rest, which is huge. Um, it doesn't cover facility cost if the patient is staying long term, but at least it can kind of give a little bit of a reprieve to family members. A lot of people out there have Medicare Advantage plans and question, is this the same thing? Is there a same amount of coverage? Let's say that you have True Blue or a Blue Cross Advantage, and that all is going to resort back to Medicare. So it's essentially the same thing. I think Medicaid also covers 100%. Kendra, is that correct? For those that qualify for Medicaid, and then private insurance can vary in coverage, just like in home care. So, again, just check your policy.
I mean, we're at a very tough time in the care continuum for someone. Mom, 85, is now moving in that direction towards end of life. You may have spent a lot of money already on different aspects of care. So that is wonderful news for a lot of people, Danny, that Medicare is going to pick up this bill in most cases. And so that can be a huge relief. Again, I've been asked that question numerous times by families. What is this going to cost me? How are we going to pay for it? I want to ask you guys in a second about any stories you guys may have of patients that you've worked with. But before I get there, is there anything else you guys would like to talk about, both from a home health perspective or a hospice perspective, before we move on to those stories?
Well, Richard, I became a nurse to become a hospice nurse, and I could speak to you for hours and hours on the topic of hospice, and home health is such an amazing benefit, and I think they both are underutilized, and so I really appreciate you bringing this onto your podcast and really allowing the listeners to learn from the services out there. We have so many patient stories from a home health perspective and a hospice perspective. I think one of the really cool things is because St. Luke's has a home health and hospice, we are able to transition patients from home health to our hospice and from our hospice to our home health very seamlessly if the need arises. And so we have great collaboration and communication and can continue to just transition those patients within their medical home of the St. Luke's Health System.
That's fantastic. And again, we're at a tough time, and obviously for the individual receiving the care, but for the family as well. And easy, seamless are great words that we're talking about here. Anything else you guys would like to add about either service, stories, etc.?
I think when people say the word hospice, they visualize the Grim Reaper walking in their home, and this is it. And maybe my life is not worth expanding at this point, and that is not the point that we want to come across. It is, we have patients that travel on hospice. They're living out their dreams, filling their bucket lists. We are there to, like Kendra said, really enhance quality of life. The How passionately we feel about end of life is like, we think it should be celebrated like beginning of life. When a baby's born, everybody gathers around, and it's a celebration. And I really think that there needs to be a little bit of a turn in our thought process to treat that the same way at end of life. You have a team, you have support, and it's a part of everybody's journey, right? So let's enhance that the best that we can.
I mean, it is reality. I'm not aware of anyone that's a few hundred years old. I mean, we fortunately or unfortunately do pass at some point. But if I can speak to this from a personal perspective, each one of the parents that we took care of went through hospice care and their final journey. It was done in the home. It was wonderful. It was peaceful. They were not suffering like they were before. I didn't know a lot about hospice before that, but it was, like I say, very peaceful. I can't speak for them. I can speak for our family, and it made end of life for our family as peaceful and as understanding as possible. So, before we get ready to wrap this up, ladies, let's talk about contact information. How can people find you? Phone number, website. What would you like to give out?
Yeah, so you can always find us on the St. Luke's website. There's St. Luke's Hospice and then St. Luke's Home Health. Our main line is the 208-381-2721, and that's our hospice line. And then Kendra, do you have the main line for our home health? You can reach that through that phone number as well, and we can get you to the right place. But
Yeah, the home health is 208-381-2138.
Excellent, ladies. This has been a great conversation talking about these services that St. Luke's Health System provides both in home health and in hospice. Hopefully, we've answered some questions for you folks, understanding how seamless this can be, movement from one to the other, how it's paid for, which is actually great news for a lot of folks. Um, so, as I get ready to wrap this up, as we always do on each episode, if you folks have questions, if you folks would like to speak with me further, you're an expert in the field, or you have stories to share, please reach out. I'm about to give you an email. That email is eldered2023 at gmail.com. So I want to thank both of the ladies for all the information they gave out, and more importantly, for all that they're doing on a daily basis to help both the patient and their family. So, as I do on every episode, folks, until we talk again, have yourself an awesome day.